إن شاء الله هنبتدي جلسة النيوكلير ايميجينج سيشن في المؤتمر السنوي الثامن لقسم الأشعة التشخيصية بطب عين شمس. أنا دكتورة رندا عبد الله، أستاذ في طب عين شمس، ويشرفني طبعا إن منورينا ويشاركونا في رئاسة الجلسة الأستاذة الدكتورة سهير قراعة، أستاذة في الطاقة النووية ورئيسة الجمعية الأفريقية للمرأة في مجال الطب النووي، الأستاذ الدكتور محمد صبري القاضي، أستاذ الكلينيكال أونكولوجي في طب عين شمس، أستاذ الدكتورة نهاد محمد عثمان، أستاذ الأمراض الصدرية في طب عين شمس، أستاذ الدكتورة منى حاتم شلبي، أستاذ الأشعة التشخيصية والطب النووي في طب عين شمس. وإن شاء الله معانا هيشرفنا دكتور هشام الغزالي، أستاذ الكلينيكال أونكولوجي في طب عين شمس. وطبعا الأول أحب أشكر أستاذ دكتور محمد أبو الهدى، يعني الأب الروحي للمؤتمر بتاعنا، والأستاذ الدكتورة سحر رفيقي رئيس قسم الأشعة التشخيصية وكل اللجنة المنظمة، والدكتورة منى بس بعد استأذنكم هتكلمنا 5 دقايق بس عن وحدة الطب النووي، لأن هي مديرة وحدة الطب النووي بطب عين شمس اللي احنا بنفتخر انها موجودة عندنا، وطبعا هي تطورت كتير من دكتورة هالة طبعا الراعية الرسمية ليها والمنشئة والأستاذة، ودكتورة منى بتكمل المشوار. فاتفضلي يا دكتورة منى.
تمام يا دكتورة رندا. صباح الخير. هدي كده بريف توك عن الوحدة عندنا. هي الوحدة أنشئت سنة 2016 بوصول جهاز البات سي تي اللي جه على ايد يعني دكتورة هالة ودكتور عمر حسين، وبعد كده في 2017 ابتدينا انضمت لينا كمان وحدة الأورام، المسح الذري من الأورام، فابتدينا كمان غير الجاما كاميرا وغير البات سي تي بقينا بنوفر راديو اكتيف ايودين ايميجينج. وفي 2021 ابتدينا نقدم فحص البي اس ام اي بتاع البروستات، ده غير بقى الفحوصات العاديه بتاعه الجاما كاميرا. ويعني وصلنا الحمد لله ان احنا في السنه اللي فاتت دي عملنا حوالي 2500 فحص جاما كاميرا مع 1600 فحص بات سي تي، وهوبفل يعني ان احنا في السنين اللي جايه ان شاء الله يعني نعمل ابجريد للبات سي تي، وان احنا نكمل وندخل فحوصات جديده باذن الله. ودلوقتي بقى هنبتدي السبيكرز بتوعنا. اول سبيكر دكتوره اميره ايمن شاهين، تلمستي وانا كنت مشرفه عليها في الام دي، وان شاء الله يعني هي التوك بتاعتها هايله جدا. هي استشاري في جامعه مصر للعلوم والتكنولوجيا. واتفضلي يا اميره نسمع بقى التوك.
Good morning, dear professors and everyone. It's my pleasure to be here today. My special thanks go to Dr. Minna Hatem Shalabi for inviting me to this conference, and my deep thanks go to Dr. Yahya Omar for his great assistance and participation in the practical part of this study. Lung cancer is one of the most frequently occurring cancers in the world. It remains the leading cause of cancer-related mortality worldwide. Prognosis of lung cancer is generally poor, with 5-year overall survival rate in a last taken has been around 21.7%. As you see here, lung cancer is the 3rd leading cause of cancer after breast cancer and prostate cancer. At time of diagnosis, 56% of patients have a distant metastasis. The survival is definitely depending on the stage of diagnosis. If patient is diagnosed in the localized stage, the 5-year survival will be approximately 60%, while in regional and distant metastasis, it goes down to approximately 6%. The 2 main histologic types of lung cancer are small cell lung cancer and non-small cell lung cancer, which is subdivided into adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Currently, the 8th edition of TNM classification staging is the most recent and updated edition for bronchogenic carcinoma staging. Accurate staging is crucial for treatment planning and determining patient prognosis. Quantification of tumor burden by medical imaging is being used to assess the effectiveness of various anti-cancer therapies in lung cancer. CT is the most commonly used radiological modality for tumoral staging and follow-up due to its availability and rapid scanning with high-resolution images. Radiological follow-up of bronchogenic carcinoma to assess therapy response using CT established by using RECIST criteria depending on size change and reduction of the tumor mass. Combining CT with PET is expected to improve accurate size and location of the tumor and also early diagnosis of progressive disease because changes in cellular metabolism occur more rapidly than do changes in tumor size. So PET-CT can provide morphological and functional information. SUV max is a significant predictive factor in treatment response of lung cancer. It has been widely used as an indicator of tumor metabolic activity because of its convenience of measurement. Radiation-induced inflammation and fibrosis sometimes make estimating the size of the lesion more difficult. PET imaging allows to differentiate the atelectatic lung parenchyma from the malignant non-malignant pulmonary reaction through its FDG uptake, thus defining the tumor in a better manner. Using CT in monitoring the rapidly growing tumors with central necrosis or hemorrhage may not be beneficial in size change detection. Therefore, using PET-CT metabolic parameters that integrate both uptake intensity and the tumoral volume may be very helpful in follow-up of the necrotic tumors. This is an example, PET-CT images of male patient with non-small cell lung cancer undergoing radiotherapy. PET-CT clarified the differentiation between the tumor and surrounding non-malignant pulmonary reaction. This is another example. Limitations of PET-CT. Several benign lesions, such as infection and inflammation, also have increased glucose metabolism and can therefore appear as a hotspot on the PET-CT image and can be potentially misinterpreted. Small lesions, less than 8 to 10 millimeter, may appear cold on the PET-CT image and have been associated with false negative PET-CT results. Minimally invasive and low-grade malignancies, such as carcinoma in situ, hypocellular tumors, and carcinoid tumor. This is a CT and fused PET-CT image scan showing a left lung lesion which appear FDG-avid. This is an example of false positive study showing tuberculosis mimicking lung cancer. This is a prospective study of a total of 20 patients. Patients were referred for follow-up after chemotherapy and or radiotherapy to assess response of treatment. All patients with a known diagnosis and pathologically proven bronchogenic carcinoma with no age or sex predilection. Only the primary tumor was assessed, whether there is nodal distal metastasis or not. Staging of primary tumors of each case was done according to the 8th edition TNM classification. Pre-treatment and post-treatment follow-up PET-CT were performed with an interval of 3 to 5 months between the two scans. RECIST criteria was used on CT interpretation as a gold standard. Patients classified as responders with an outcome of complete response or partial response. However, patients classified as non-responders, those who had an outcome of stable disease or progressive disease. This is a quick note on the descriptive statistics of the population in this study. So the aim of this work is to prove that SUV max is a good predictor of treatment response. We have 3 values of SUV max: pre-treatment, post-treatment, and percentage change of SUV. Another quick note on the statistical operations of this study. I'm not going to go in details on this. So when responder and non-responder groups were compared, no significant difference was found between the pre-treatment SUV of both groups. However, post-treatment SUV and percentage change of SUV were significantly lower in the responder group than non-responder group. Then, in effort to determine whether SUV can differentiate between the individual groups, namely progressive disease, stable disease, partial response, and complete response, comparisons of the various variables between the 4 groups were also performed. And then more statistical operations were done based on more accurate information and resulted in no significant correlation was found between pre-treatment SUV values and pre-treatment size values. However, a moderate positive correlation was found between post-treatment SUV values and post-treatment size values. The strongest correlation was demonstrated between percentage change of SUV and percentage change of size values. This is a scatter diagram displaying the strong positive correlation between percentage change of size and percentage change of SUV in all patients. This is to be expected as metabolic progression is almost always accompanied by increase in the size of the lesion. This is a CT scan of the chest before and after therapy. An old male patient presented with history of right lung neoplastic lesion under chemo radiotherapy and referred for follow-up after 4 months. It shows a morphological regression. Fused PET-CT images showing metabolic regression of the mass currently achieving 15.3 SUV max compared to 33.5. It is seen developing a large central photopenic area of necrosis. Whole body MIP images before and after therapy showing marked metabolic therapeutic response. CT and fused PET-CT images of an old male patient with a history of left-sided lung cancer referred for follow-up after 3 months of chemoradiotherapy, showing interval progression of the size and the metabolic activity of the lesion, achieving 22 SUV max on the follow-up examination compared to 10 SUV max on the baseline study. Coronal images. Whole body MIP images before and after therapy showing progression of the primary left lung mass. CT and fused PET-CT images before and after therapy. An old male patient with a history of right lung cancer referred for follow-up after 3 months, showing complete resolution of the neoplastic right lung mass, currently not exceeding 1.1 SUV max compared to 10.1 SUV max previously. It also shows a remarkable reduction in size. Whole body MIP images before and after therapy showing the complete therapeutic response of the right upper lobe neoplastic mass. This is the last case. CT images before and after therapy. An old male patient presented with a history of left lung cancer under treatment and referred for follow-up PET-CT after 3 months, showing rather stationary appearance of the identified left lower lung lobe lesion. PET-CT fused images showing rather stationary appearance of the lesion, currently achieving minimal lesser activity, 10.6 SUV max compared to 11.6 SUV max previously, it shows central photopenic area of necrosis. Whole body MAP images before and after therapy showing stable metabolic response. In this study, a close correlation was found between SUV max and response to therapy according to RECIST criteria. SUV max of the primary tumor changes from 2 serial PET-CT studies before and after therapy, so it can differentiate between responders and non-responders in early course of chemoradiotherapy and leads to significant change in therapeutic and management strategy by avoiding ineffective chemoradiotherapy and by supporting the decision to continue the primary treatment in responding patients, and this hopefully will improve the patient's outcome and prognosis. Finally, PET-CT proved itself as a useful, efficient, and reliable tool of investigation and in initial staging and follow-up of lung cancer patients, and recently became a part of the international guidelines in the diagnosis and follow-up of cases with bronchogenic carcinoma. Thank you.